Assalamu alaikum wa rahmatullahi wa barakatuh. Hi guys, this is Shahadat, and today I'm going to read a scientific paper for you. And this is the fifth video in this particular series. This particular paper that I'm going to read was published in openaccessjournals.com and under the diabetes management section. The title of the paper, as you can see in the screen, is Clinician's Guide to Inpatient Low Carbohydrate Diets for Remission of Type 2 Diabetes Towards a Standard of Care Protocol. The paper was authored by Mark Cucuzella and then Adele Height, Caitlin Patterson, Laura Saslow, and Rory Heath. So let me move on to the other screen. Right. In the previous video, the fourth part, I read up to here, and I'll start from this section called discharge and follow-up in this video today. So without further ado, let's start. Let me make the screen a bit bigger. And discharge and follow-up. Prior to discharge, the healthcare team should review medication changes and home monitoring of blood glucose and blood pressure if on medications. Patients should be educated in a safe medication reduction strategy and should have immediate access to an appropriately trained healthcare provider for any questions or concerns. Although resources may vary according to clinic or hospital staff, contact email and cell phone numbers should be available to patients. To avoid confusion, electronically generated discharge forms which might contradict the LCK intervention should not be used. For example, if a patient has a diagnosis of T2DM, the standard hospital instructions often recommend 60 gram carbs per meal with 15 gram carbs snacks. Printed discharge instructions for hypertension and heart failure often advise salt reduction to less than 2 gram per day. These instructions are not appropriate for patients following a LCK diet. Patients should also be empowered to take charge of their health with the support of family and their healthcare providers. The patient should check blood pressure and blood glucose daily, including some postprandial readings 1 to 2 hours after a meal. Medication, blood pressure, and glucose logs are an indispensable part of safe and optimal care. See Appendix 1 for examples. Having the patient record weekly waist circumference and body weight measurements may also be helpful in monitoring progress. A dietitian trained in carbohydrate reduction can assist patients with identifying and overcoming barriers to adhering to this intervention, including limited financial or time resources, trigger foods, food addiction, and eating out. Outpatient follow-up is essential until new medication regimen is optimized. Medication titration may need to occur multiple times as insulin resistance improves. If a member of the hospital healthcare team is not the primary care provider, contact the primary care provider and let them know of the dietary intervention and accompanying medication changes. For Jefferson Medical Center, an outpatient clinic at WVU Center for WVU Center for Diabetes and Metabolic Health often assist after hospital discharge. Return visits allow additional opportunities for education and encouragement. Laboratory workup should be completed about 3 months of initiating the dietary intervention. This should include a complete metabolic panel and HbA1c. Waiting at least 6 months to repeat lipid panel is advised. The primary care physician should continue to check HbA1c every 3 months, adjusting medications as necessary. Clinicians should be cautious in discontinuing long-acting insulin in anyone with possible irreversible beta cell dysfunction due to autoimmunity injury or beta cell failure of long-standing T2DM. Most patients will notice a dramatic decline in triglycerides or TG, increase in high-density lipoprotein HDL cholesterol, and decrease in HbA1c. Although some patients will also show an increase in low-density lipoprotein LDL cholesterol, a recent meta-analysis of low-carbohydrate diets and lipid effects shows an overall favorable response, concluding that large randomized control trials of at least 6 months duration with carbohydrate restriction appear superior in improving lipid markers when compared with low-fat diets. Dietary guidelines should consider carbohydrate restriction as an alternative dietary strategy for the prevention or management of dyslipidemia for populations with cardiometabolic risks. Reference 39. The role of LDL cholesterol alone as a risk predictor in cardiovascular disease is tenuous. Reference 37. Therefore, the patient's atherosclerotic cardiovascular disease ASCVD risk should be recalculated with the new laboratory markers including TG and HDL cholesterol. In almost all cases, the patient can be reassured of their risk panel if slight LDL cholesterol elevation. If slight LDL cholesterol elevation. Larger elevations of LDL cholesterol, if they occur, would require an individualized treatment plan. Next section, case study. DT is a 41-year-old African-American law enforcement officer with a recent diagnosis of T2DM when he presented to Jefferson Medical Center in June 2017 with a glucose of 700, HbA1c of 14.9, and serum creatinine of 7. Other significant medical history include hypertension, gout, hypercholesterolemia, and obesity. His diabetic pharmacotherapy at the time of admission was long-acting insulin degludic injection, 15 units daily, metformin 1 gram twice daily, lisinopril 40 milligram daily, metoprolol, hydrochlorothiazide 50 milligram or 12.5 milligram daily, and simvastatin 40 milligram daily. With intensive hospital management of hydration and insulin, renal failure improved and he avoided hemodialysis. Due to extreme insulin resistance, he was discharged on 70 units of insulin glargine twice a day and short-acting insulin Lispro up to 20 units before meals. Following the protocol outlined above, he was introduced to the option of low-carbohydrate eating. He was interested in pursuing this option and arranged for a quick follow-up after discharge. 2 weeks after discharge, his creatinine was down to 1.16 and glucose normalized on 20 units of long-acting insulin a day. DT continued to follow a low-carbohydrate, sugar-free diet and was able to stop insulin completely within a month after discharge. On metformin alone, his HbA1c results have been 6.7 at 3 months after discharge, 5.8 at 13 months, and 5.9 at 17 months. He has been discharged from the renal clinic, reduced close to 100 pounds of body weight and several inches of waist, and returned to his job and youth coaching. From near dialysis in June 2017, he has been able to maintain health improvements for over 17 months and now has the opportunity for a healthy future. Discussion. Remission of prediabetes and T2DM has not been fully defined or agreed upon in the literature, as T2DM is most often treated as a chronic progressive condition. However, remission indicates the reversal or disappearance of signs and symptoms, which can be temporary or permanent, and this can be achieved in T2DM with therapeutic levels of carbohydrate reduction. Prediabetes may be considered to be put in remission with a HbA1c measurement of less than 5.7 and T2DM reversed with a HbA1c measurement of less than 6.5% with or without the use of an insulin sensitizing agent such as metformin. Remission can be defined as two measurements below these thresholds at least 2 months apart, again with or without the use of metformin. Reference 40. Although the benefits of carbohydrate restriction for individuals with T2DM are recognized, many experts have raised concerns about whether patients can adhere to such a diet indefinitely. Because dietary carbohydrate is not an essential nutrient, reference 23, a well-formulated LCK diet that includes a variety of vegetables present no health risk for nutritional deficits. However, other considerations such as traditional or celebratory foods should be taken into account when discussing long-term adherence to a low-carbohydrate dietary intervention. In the context of selection of highly motivated individuals or administration of programs that encourage high adherence, remission of T2DM is possible. Reference 2241. In terms of sustainability of this intervention, a recent survey of participants voluntarily adhering to a low-carbohydrate diet suggests that weight loss and diabetes remission is sustainable when a low-carbohydrate diet is incorporated as a lifestyle change. Reference 41. The survey found that before respondents started a low-carbohydrate diet, nearly 9 of 10 experienced intense hunger between. The survey found that before respondents started a low-carbohydrate diet, nearly 9 of 10 experienced intense hunger between meals. Once on the diet, only 3.5% said that they grew hungry between meals. Respondents reported similar improvements in other aspects of their physical and psychological well-being. Of the 1,580 survey participants, more than half reported staying on a low-carbohydrate diet for at least 1 year, with 34% using the intervention for more than 2 years. Further, those on the diet for 2 years or more said that they had largely maintained their weight loss. This is a self-selected sample with an obvious bias for people who are experiencing success. However, this data does show that long-term adherence is possible, whether or not and in what manner to allow additional dietary carbohydrate to the diet will be an individual decision. It is unlikely that a return to previous levels of carbohydrate consumption would be recommended. To do so would likely lead to a return of previous health conditions that reduction of dietary carbohydrate ameliorated. However, as with other dietary components that are non-essential, such as alcohol, limited amounts may be tolerated. For some individuals, increased dietary carbohydrate may be offset by deliberating restricting calories in a way that prevents weight gain. Other individuals may prefer to forego calorie counting in favor of continued carbohydrate restriction. For individuals with remission of T2DM, a reintroduction of dietary carbohydrate requires continued blood glucose monitoring and regular HbA1c measurements. Next section, outpatient settings. Many patients eligible for low carbohydrate therapy and medication reduction present in ambulatory settings. Although the protocol described here was designed for use in an inpatient setting, it may be adapted to an outpatient setting. Patients on insulin therapy may benefit significantly from a LCK dietary intervention in either setting, but they present significant challenges in medication management given the time constraints of the outpatient environment. In this case, consideration should be made for inpatient initiation of LCK diet and medication management for poorly controlled cases of T2DM, especially if severe comorbidities are already present. Otherwise, patient education and community support for physicians and allied healthcare providers is especially important with regard to medication management as dietary carbohydrate is reduced. Ideally, as with the nurses, dietitians, and health coaches will no, let's start again. Ideally, as with the inpatient setting, a multidisciplinary team of providers, including clinicians, pharmacists, nurses, dietitians, and health coaches, will collaborate on patient care. Something as simple as cell phone technology can greatly assist clinicians in the successful use of this intervention. Daily text messaging between the patients and the physician or another trained team member allows medication reduction to be safely tailored to the patient's needs. In a community setting, opportunities to meet and socialize with others using low carbohydrate dietary interventions may assist with supporting individuals in making dietary and behavior changes. For example, at WVU Center for Diabetes and Metabolic Health, where patients from Jefferson Medical Center frequently receive follow-up care, the group visit model is being used to support patients and families in making necessary lifestyle changes. Next section, additional considerations. This article has focused on the use of LCK dietary intervention to treat T2DM initiated in a hospital setting. However, there are other conditions for which this type of intervention may be appropriate. Individuals with metabolic syndrome, METSIN in short, may also benefit from dietary therapies that reduce carbohydrate. Identify these individuals and placing them on an individualized low carbohydrate intervention may help prevent progression of further metabolic dysfunction and the development of T2DM or other chronic diseases. Various definitions and sets of identifying criteria for medicine have been put forth. Reference 42. The following conditions are considered to be related features of metabolic syndrome. An individual presenting with 3 or more of these conditions can be identified as having METSIN. First, a large waistline. Waist times 2 is greater than height. This also is called abdominal obesity or having an apple shape. Excess fat in the stomach area is a greater risk factor for heart disease than excess fat in other parts of the body, such as on the hips. Next, a high TG level, more than 150 mg per deciliter, or on medicine to treat high TG. Next, a low HDL cholesterol level, less than 40 mg per deciliter for males and less than 50 mg per deciliter for females, or on medicine to treat low HDL cholesterol. Next, high blood pressure, more than 130 by 85, or on medication to treat high blood pressure. Next, high fasting blood sugar, more than 100 mg per deciliter, or on medicine to treat high blood sugar. Clinicians should note that the above criteria may be inadequate in identifying METSIN in African American populations. Elevated triglycerides are closely associated with lower HDL cholesterol, which suggests a redundancy in clinical criteria for METSIN that is beyond the scope of this paper. but which may exclude from medicine diagnosis populations that do not demonstrate this dyslipidemic profile. Reference 43 through 45. A diagnosis of medicine suspected from family history of T2DM or other indications may need to be ascertained through more direct measures of insulin resistance. Low carbohydrate diets that are restricted to ketogenic levels have been used as therapeutic diets for epileptic seizures for a number of years. Reference 46. There is a robust literature on the implementation and effectiveness of these diets. However, clinicians should note that these diets are distinct from low carbohydrate diets used to treat T2DM in that they tend to be far more restrictive and are directed at other considerations such as the generation of ketones for the therapeutic purposes besides minimizing blood glucose excursions and subsequent insulin demands. Low carbohydrate diets have also been proposed as interventions for many other health conditions including obesity, polycystic ovarian syndrome or PCOS, gastroesophageal reflux disease or GERD, non-alcoholic fatty liver disease NAFLD, and gout. Reference 35, 47 through 50. Many of these have limited evidence secondary to little research. However, the principles of this guide may be used for safe implementation of low carbohydrate diet for other clinical presentations as the research and clinical experience for using this intervention for those conditions expands. Conclusion. Low carbohydrate diets are not a new intervention for treatment of T2DM. A textbook published in 1877 indicates that carbohydrate reduction is the preferred treatment for patients with diabetes. It says, quote, "There are few diseases which present to the practitioner so clear an indication of what is to be done. A diabetic should exclude all saccharine or sugary and farinaceous or starchy materials from his diet." End quote. Reference 51. Leading endocrine societies are now rediscovering this treatment. The American Diabetes Association's or ADA's October 2018 joint position statement with the European Association for the Study of Diabetes or EASD approved use of a low carbohydrate diet as medical nutrition therapy or MNT for adults with T2DM. Reference 52. The ADA's recently released Standard of Medical Care in Diabetes 2019 includes in its lifestyle management guidance the use of low carbohydrate diet as nutrition therapy, reflecting the organization's emphasis on a patient-centered individualized approach. Reference 53. The ADA and EASD both recognize that LCK diets can be a safe, effective way for people diagnosed with T2DM or prediabetes to normalize HbA1c levels while lowering medication therapy, reducing the risk of hypoglycemia or other adverse medication effects, and assisting in weight loss. In this review, we highlight recent trials on the topic, but more importantly, provide clinicians with guidance for implementing this kind of dietary intervention in their own hospitals or clinics. In providing a clinical protocol for using LCK dietary intervention, this article offers the foundations for a shared language for clinicians to use in discussing and comparing interventions, improving protocols, and managing shared concerns. We do not expect this guidance to provide a one-size-fits-all approach to care. Rather than we expect that knowledge gained from the clinical experience of others will inform a continued improvement in how low-carbohydrate dietary interventions are used to treat patients. We do, however, anticipate a necessary change in how we discuss the course and treatment of T2DM with patients. With a simple, safe, effective dietary intervention, we can change the conversation around T2DM from one of progression to one of remission. Funding. Laura Seslow's time was supported in part by National Institute of Diabetes and Digestive and Kidney Disease, NIDDK, K01DK107456. Seslow is the reference. So I'll stop here because the rest of the paper has got all the references in it. Because I'm going to share the address or the URL for this paper, you can obviously go back and check the references there. So I wanted to record this whole thing in a audio format because I understand doctors are really busy and they don't have time to read scientific paper on a daily basis probably. So putting it on the audio version, I hope that they will be now able to listen to this audio version and on their way, probably when they are traveling or something like that, when they have got a bit of free time, they can listen to it and they can educate themselves, they can improve their knowledge, and that will help the way they look after their T2DM patients. So with that, that's the end of this series. So I'll hope to see you next time in my other video or next video, whatever that is about probably. So take care. I'll see you later. Bye-bye.